This is Enrique Bakemeyer with Healthcare Business Insights. I'd like to welcome you to today's Thought Leadership webinar hosted with PMMC, Adapting to New Reimbursement Models, How to Prepare Performance and Maximize Revenue. On slide 2, you will have the opportunity to ask questions during the webinar by typing them in the space provided in the open Q&A field on the right-hand side of the screen. We have a couple of brief pauses to field questions on slides 15 and 23 and at the end of the webinar. If at any point during the webinar, please call our membership services team at 888-700-5223 for personal attention. As always, today's program is being recorded, and registered attendees will receive a copy of the presentation by email within the next couple of days. In earning CPE credits for this session, please don't forget to fill out the post-conference survey at the conclusion of the event. You have to fill out the entire survey, just the first question about CPE credits, and we'll send the certificate to you. Before we get over to our speakers, let's spend a few minutes establishing the context for today's discussion and also launch today's first in-conference poll. The question is, have you negotiated a value-based contract in the last 6 months? The answer is yes, no, currently in negotiations. Again, the question is, have you negotiated a value-based contract in the last 6 months? The answer is yes, no, or currently in negotiations. Sort of begin the topic by perhaps stating the obvious. We're living in a changing world on many levels in healthcare. And specifically in terms of contracting, what we've heard from our members for some time is that reimbursements have been declining, that there are more risk-based contracts in play, and therefore there is a need among providers to hold payers accountable for meeting their end of these agreements. One organizations have attempted to adapt to these changes is through a committee or council or a type of group to review contracts and also track payer performance. The last time polled on this issue, we found that 60% of members had such a committee. Case studies on how contracting committees function. Briefly touch on one Midwest organization that we studied recently. Discussed with us the origin and structure of their contracting council. Originally, that organization's vice president of managed care reviewed all contracts and did all negotiations, but after some time, leaders realized the need to involve others in the contracting process. So when the contracting council was first formed at that organization, everyone in the council reviewed contracts, but then that also became unfeasible due to the difficulty of aligning everyone's schedules, as one might imagine. The council then formed subgroups to handle different aspects of the contracting process. For example, one subgroup made up of the director of managed care contracting, a contract manager, reimbursement analyst/auditor, and reimbursement supervisor is responsible for all negotiations. Also done some research on how to monitor payment variances, another that will come up in more detail later in this presentation. One example comes from our consulting and analytics team. They worked with one multi-hospital system that noticed a net revenue decrease, but didn't see correlated decrease in contracted rates among its payers. In this case, it was identified that the contracted rates were not updated appropriately and accounts were not properly running through the logic within the contract management system as designed. More detailed versions of these two case studies I've touched on briefly, or if you'd like to access any of HBI's research on contract management, we have an implementation portfolio on our web portal called Managing Effective Payer Contract Negotiations and Monitoring Compliance, with collected studies, presentations, and tools. A couple examples of the type of reimbursement changes that everyone has been working through recently. Certainly everyone is familiar with changes related to MACRA, under which CMS has announced its intention to shift to value-based reimbursements. As you may be aware, CMS has some proposed changes to MACRA for year 2, like raising the threshold on who has to participate so more low-volume providers won't have to comply and not really counting cost again for at least 1 year. Another example of a new reimbursement model that has had wide-ranging impact is the Comprehensive Care for Joint Replacement model originally introduced in 2015. Under this model, providers will be penalized or rewarded based on how close they are to a target price for joint replacements established by CMS. Central payers often follow CMS's lead on reimbursement methods like MACRA and CJR are just a couple of the reasons why it's not surprising tracking payer performance is on the minds of so many revenue cycle leaders and members. The CGR model is also notable in that it was the subject of two previous HBI webinars in 2015 and 2016, also hosted by PMMC. I'd like to introduce our speakers for today's webinar. We're delighted to welcome Greg Kay from PMMC, Abby Thompson from Texas Children's Hospital. I'd like to introduce yourself at this point, and you can take it away from here.
Thank you much, Enrique. We do certainly appreciate your time, Jason, Beth, everyone at HBI helping coordinate today's session. We do appreciate all of the attendees that are on the call today. Cabby, would you say a few words as an introduction?
Yeah, my name's Cabby Thompson. I'm Director of Managed Care at Texas Children's, and we do work closely with PMMC on our contract modeling.
Cabby?
Mm-hmm.
Organization is Senior Vice President. I've worked in healthcare for 28 years. Have been with PMMC for 20. And with today's session, we're going to be focusing in on the contract governance or contract management process. Management has been an evolutionary process, as many of you know. It began with an initial shift away from bill charges years ago, and as the section touched on a few moments ago, Enrique mentioned CMS's new risk management process with CJR, looking to shift risk from the payer out to the provider. This process started many, many years ago. CMS first introduced DRGs. That process moved on into managed care, and the driver of the contract management evolutionary process over the years has really been around risk mitigation. How do we manage risk? And for healthcare finance departments, this is managing reimbursement as compared to the cost of care. We look at the contract governance process. Our organization has defined contract governance really in four key areas. One being contract analysis and modeling, the front negotiation process. Two being the expected reimbursement calculation, typically the application or tool that you have as a part of your billing process. Through the variance monitoring workflow, so will the claim, calculated the expected, did the remit from the payer, identifying any variances at that particular point, and then lastly, step 4 being the payer scorecard and reporting, analysis of those components, and step 4 feeds back into the contract negotiation process by taking what actually occurred, compared it to what was modeled to negotiate new reimbursement scenarios. So it's a cyclical process that does follow a hierarchical step and move through the reimbursement flow. Now, another layer to those 4 steps in the process, there are typically 4 roles or parties that are involved in this cyclical process: the negotiating team and reimbursement audit process team, and that being teams for both organizations. With contract governance, there should be a documented process, whether it is with one individual or multiple individuals. That documented process should be very clear. It should be maintained, should be followed for a higher level of accuracy. And externally, as we find the process between managing the process between the negotiators, it is extremely important to define everything. Everything. PMMC has loaded over the years over 500,000 contracts, and clearly defining everything down to how clear are the contracts, how clear are the rates and the terms, as well as the payer payment process rules, such as authorization, appeals, etc. Because it leads to the internal communication. Once you've negotiated the contract and you're communicating to your internal team, it is extremely vital to ensure that you're communicating all of those steps, the reimbursement provisions, your internal staff, so that they can manage the process and go forward. Now, adage, money is made when you buy, not when you sell. Treatment is very applicable to our industry, and for our clients and healthcare providers, this means modeling the payer contract rates and terms. Using data is critical to really understand the key variables. Anecdotally, I've found the most common negotiating tool in the industry today is Microsoft Excel. Excel is probably the tool that is most widely used by managed care departments and healthcare organizations. Using other systems as data repositories and analytical tools, but too often when it comes down to actually negotiating the reimbursement provisions, Excel, while it's a terrific application, doesn't always handle all of the reimbursement variables that would be needed. Now, really can come in all shapes and sizes. When we look at payer contracts, what we want to focus on is the different reimbursement provisions and how to manage and negotiate risk associated with those methodologies. Bill charges has the lowest level of risk. On the surface, these agreements should be the easiest to manage, and often for most organizations, discount off of bill charges probably are the highest number in terms of just number of contracts that organizations have. These are often old agreements that have evergreen terms. Many organizations will keep these older contracts in play, but they have not, because of the evergreen contract nature of the agreements, gone back and really revisited those contracts. Often payers do have the ability to update payer payment processing rules, the authorization process, the appeal process, often modified over time. So these contracts are often not as profitable as you may think they are. Certainly, for every organization, would be worth revisiting those from a negotiation standpoint. The area is fee-for-service. This is most widely method today. 93% of all reimbursement falls under some type of fee-for-service arrangement today. This typically will include Medicare, Medicaid plans, all of your commercial plans. The risk involved with fee-for-service arrangements in different organizations have stepped out and taken on more or less risk, depending on whether you're looking at per case rates, per diems, and then incorporate other areas of reimbursement methodologies, such as outliers, per unit calculations, ranging from these APR, DRGs, ICD codes, revenue codes, CPT, HCPCS codes. There are lots of ways that different payers and payers have come with reimbursement methodology. With some payers, such as Medicare and Medicaid, you have little to no leverage with negotiating rates and terms, but you should model those contracts to really understand what future holds for your organization prior to those agreements going into effect. With your co-payers, really regardless where you are today, there are always areas to look for new reimbursement methods. Every organization should be willing to model, analyze, and look for reimbursement changes based upon your actual mix of service. Moving from the current methodology into evolution of the next phase, if you will, payers and providers are on new risk as it relates to pushing the fee-for-service methodology to a new level. They're tying quality benchmark metrics to reimbursement, such as value-based reimbursement, bundle payments, and shared savings. Similarly, as was touched on earlier in the site section, CJR is an example of CMS forward with new bundle payment methodologies, and again, putting the risk, if you will, onto the providers to manage the care associated with patients. This year, Modern Healthcare recently conducted a survey, and it was noted as it relates to risk-based contracts. Out of 60 respondents, derive 10% or more of their net revenue from risk contracts. Very consistent with a similar rate of organizations that derive that much revenue from agreements. From their survey group, 45 of the 60 participants noted that generating 4% or less of net revenue from risk contracts. Those organizations were very committed to continue on this pathway. Modern also noted in the article that for organizations to really successful with the newer payment control arrangements, having the infrastructure in place to really delve into new value-based payment arrangements are critical to really see a return on their investment. Cabby, what's your experience today with reimbursement provisions and risk-based contracts?
All of these different types of reimbursement, I would say that the discount from bill charges is kind of today's magical unicorn. They're hard to come by, and the ones that are there are likely to become extinct in the near future. So hang on to it, but do monitor it. It's easy to become lax in the monitoring of how that contract is administered and operates within your system. But to seeing a shift in reimbursement to transfer risk from the payer to the provider. So we've seen that in the implementation of value-based and alternative reimbursement models such as ACOs in Texas and in several other states across the country. We've seen a push in the Medicaid arena toward value-based reimbursement. So the states are requiring the Medicaid plans to have a certain number of value-based contracts, a certain percentage of reimbursement falling under alternative reimbursement types, and that percentage amount grows year over year. In order for those plans to maintain their funding from the state at a full amount, they have to meet those benchmarks. On the commercial side, the plans are trying to engage the providers in managing costs by giving them some skin in the game, beginning with shared savings, and then slowly escalating towards shared risk with of course, the final target. They love capitation. So in exchange, the provider are being offered steerage through network models, which I'm sure most of you have seen. Our network models, though, don't appropriately provide for network adequacy, especially in the pediatric arena. The pediatric specialists are not accounted for separately. Children's cancer hospitals, specialty hospitals, are typically excluded from narrow networks because the health plans fear adverse selection. So we've happened in the marketplace plans. Many of the news headlines over the past couple of years have been about cancer patients who lost their access to their provider for the treatment that they were seeking. Bundled payments, in my experience, most of the plans haven't been capable of administering bundled payments. And in conjunction with that, for value-based reimbursement, a lot of the plans have a hard time, if you're in the pediatric arena, getting a program that's specific to pediatrics. So if you're in a specialized hospital, it's hard to pursue those types of agreements. But we've most definitely seen a shift
Absolutely. And note, next month we'll be conducting follow-up commentary session to today's topic on neural network models. Kathy brings up a great point. Neural networks are that a lot of organizations are proactively and some are reactively moving the narrow network models. As we're looking at bundle payments, shared savings, narrow networks do provide an ability to begin managing the population health component. And next month with HB, we'll be reading some of the pros and cons of being in a network, and some of the cons of finding yourself outside of a narrow network model. So you'll want to be look out for that. As we look forward, and we start, again, keeping a concept of contract governance in mind, leveraging technology, being its component, contract management is extremely critical. Ensure that there is a balanced relationship between the payers and providers. But there are two other groups, one of which we've referenced, the other we haven't, and that's government organizations and patients themselves. Patients more involved with introduction of healthcare savings accounts or HSAs. This is back in 2003, and over the years since then, we steady rise in high deductible health plans where patient portions have risen steadily, and patients are responsible for a larger and larger portion of their medical bill. Today, with deductible health plans, it is very common to get a $2,500 individual component. $7,500 or more is very common for family plans. And according to data from a recent Kaiser Family Foundation employer benefits survey, nearly 30% of the employees nationwide in 2016 were under health plans with a healthcare savings option. So employers are looking to control cost, obviously getting the patients to have more skin in the game, if you will, is one way that many organizations have gone about that approach. From a government perspective, tying that thought in with this, as we all know, Dr. Tom Price, the new Secretary of Health and Human Services, has been a vocal advocate for high-deductible health plans, and recently stated that he believed healthcare savings accounts and high-deductible catastrophic coverage are things that make a whole lot of sense for many individuals. So this into play as it relates to contract governance when we start to think about the patient responsibility and or negotiated reimbursement, which is allowable when it comes to the patient portion, takes a new leverage of importance since they are becoming a larger portion of your patient's revenue cycle. So when we think about negotiating payer contracts, there is also that component of patient that's out there, and they're more frequently going to be responsible for 20% of the allowable, which $15,000 bill charge with a $7,500 allowable, you're collecting $1,500 to $1,500 from the patient. So the level of accuracy with your payer contractual reimbursement and putting information out to the front end is not important during your process with the payer, but it's all tied into that communication process, and when you collect from the payer either on the front or the back end, really knowing and ensuring that you've got an accurate control reimbursement available. The bottom line is it just comes down to managing risk. So when you are negotiating risk-based contracts, or paid, willingly or unwillingly, depending on whether you're in a program or not, that risk is the key thing that you're looking to do. That's incorporate per diems or case rate scenarios with add-on or stop-loss provisions, or looking to incorporate outpatient surgical case rates or additional layers of value-based contracting. Managing risk typically starts on the front end by identifying your base services and how those services calculate on different reimbursement scenarios during the front end negotiation process with your payers. I believe we should.
Yeah, Greg, we'll take it from here for just a moment, and we will pause at this time for our first scheduled Q&A break. First, I'll share the results of our first in-conference poll. As a reminder, that question was, have you negotiated a value-based contract in the last 6 months? Results are yes, 34.5%, no, 59.5%, and currently in negotiations, 6% of you said you are currently in negotiations. We will our second in-conference poll. Is how frequently do you review data on payment variances from your payers? The answers are weekly, monthly, other, or we do not regularly review payment variance data. Again, that question is frequently do you review data on payment variances from your payers? And are weekly, monthly, quarterly, other, or we do not. And we will begin the Q&A. As a reminder, you can submit questions in the Q&A box or through the chat feature. We do have some questions queuing up right now, and here's one for you, Greg and Cabby. When a proposed contract kinds payment arrangements, bundled payment that includes value-based criteria with tax reimbursement, how should contracting negotiations be adapted?
To address that first?
That's a good question. I have not had that scenario come up, but I believe that you need to mitigate your risk and make sure that you've modeled for all scenarios. So if the proposal came across as through a value-based contract, including the bundled payment, be prepared to potentially offer something as a counter. So instead of bundling a payment, perhaps you could look at case rates that are similar but have to reduce the risk.
All right, another question coming in. My organization does not have contract modeling software. What are low-tech ways I can predict a proposed contract's effect on reimbursement? And I do believe you had mentioned Excel earlier.
Excel is definitely one way of going back, modeling, and step back, Enrique, on the first question, the bundle payment value question. The one that I would add to Cabby's comments were when you're going through the process, you should first define what the baseline arrangement or term going to be for both the professional and technical components, and you'll want to model that out through your actual claim history. The other thing that we recommend is to utilize data. CES has a wealth of information from an episodic data source standpoint. Use that data as a benchmark for your organization as well as the market if you would define it. So there are different ways to benchmark your starting point and then model out using a defined fee-for-service baseline to really understand where you fall related to your peers and where you fall related to your actual history before jumping into a full upside and downside risk arrangement.
All right, take one more for this break. Should a healthcare organization attempt to have a certain percentage of its contracts for different types of payment arrangements? So, for example, if one major payer requests a value-based contract, should we attempt to negotiate a fee-for-service contract with another major payer to offset it?
My thought is that if you're doing a value-based contract with one payer, you should really look at doing them with all of your other payers. So if you think of it in terms of what you're trying to accomplish, most of those agreements will require that you meet some sort of reduction in medical costs in addition to quality measures. So whatever you implement across your system with your physicians, with your hospital, whatever it may be, you're likely to be doing the same thing for your entire population. So while you're starting to reduce that low-hanging fruit of medical costs for one payer, you're probably doing it for the other. So if you wait to do value-based contracts with the other payers, then you won't have as much opportunity. It's sort of like sending a skinny to fat camp. He doesn't have as much weight to lose.
Thank you, Cabby. I will now advance the slide and turn the presentation control back over to you, Greg, and you can take it from here. Thanks very much.
Great. So we've modeled the purpose contractual reimbursement provisions. You've agreed to rates and terms with your then have to manage the process. And this starts with the second point, which was expected reimbursement accuracy, and moves on to the third component of variance monitoring workflow. Now, education process, industry literature notes that 85 to 90% of all claims are paid correctly the time through the process. Its workflow process incorporate a hierarchical approach, and you want to go after the things then collect with the least of effort first. Includes when you're developing your hierarchical approach, both the time it takes to appeal payments, as well as the resources to communicate the variance issue to the payer and the routine follow-up. In your workflow process, you want to value the claim time bill. So you have a slow pay, no pay, a soft denial. On your first level of appeals, you have some sense of once we have recouped the amount and the payer has successfully processed the claim, what does it look like from a net revenue standpoint? Ideally, you want to begin moving away from valuing everything off of charges and use your contract management system to know what your net patient revenue is going to be at time of bill. At time first level, again, looking at slow pays, no pays, your soft denials, where there's typically a high level of success with first level follow-up. Your follow-up is going to be what's often referred to as hard denials or the medical necessity denials that all require clinical documentation and a higher level of expertise. And following each payer's requirements and time frame for the appeal is critical to the success with that level or denial of process. The third level for many organizations is contractual variance piece. This is to have all of the claims go through the normal adjudication and follow-up process as a first pass, and it allows you to then understand the value of what you should have received based on payer contracts and what you actually received in terms of the contractual reimbursement or the allowable from the payer. What's been your experience in that workflow?
It's really important to know how your contracts are performing and equip yourself with all of the data and information. For example, if you are expecting X amount of reimbursement, but you're receiving Y, what's the difference? How did that happen, and how can you make up that difference in a new contract when you're in negotiations? So taking that information with you to the table, know which numbers are before walking into the room, and model a few different scenarios that enable you to know what your options are in advance.
today, we typically contractual variances range 1 to 4%, meaning the payer contractually underpaid you this frequently. Root cause analysis leads to administrative errors that need to be addressed. There can be true contractual variances that are collectible, as well as administrative variances that are false variances, if you will. Abby, what's been your experience?
So we did some false variances. A good example of those would be potential registration on the end, maybe put them with the wrong plan, so it's not a variance when you put them into the right bucket. But a variance can also mean you need to take a look at how you've loaded your contract. Did you load it correctly? Did you interpret it correctly? It could also mean that the payer didn't load a contract correctly. Catching it quickly will help to reduce unnecessary AR. So for the first 90 days or so after a new contract goes into place, it's really important to track AR to make sure that the contract is performing. If not performing, then you want to take a look at modeling. Did you maybe overlook something? So some of the things that you could have overlooked were lesser of language. Did you put the language in there? And if you put it in there, did you put it in there correctly? So is your lesser of language set up to lesser of for claim or lesser of for a line item? What's the language in your contract? Did you build the annual charge master increases or additional inflators into your model? Did you all of the case rates if they have holds, if there were per caps, any short stay clauses such as inliners, any service bundling rules, for example, imaging. So if sites, DR cap, that's something that we see specifically in Texas tied to Blue Cross of Texas, and you see it in other areas tied to other Blue Cross plans. Make sure to review your inpatient outpatient charges and changes separately as well as combined so that you can rule out anything in those particular areas, and then look for increases for each individual area to make sure that you don't have any unintended outcomes in your model. And then be familiar with rates in similar contracts. So if you see a huge discrepancy from one contract to the next when the methodology is very similar, you'll want to check to see if you have something set up wrong in your model. And if it's not wrong in your model, then there's got to be something in the way that you're getting paid that's incorrect. And then pay attention to how many claims and how many dollars hit stop loss. You should have kind of a standard amount of claims that you think should hit stop loss. Maybe 3 to 5% of the claims hit stop loss. No more than 5% of your dollars for sure. Did you set up your implant carve-outs correctly? Are there thresholds? Same with drug carve-outs. Are there thresholds? And then, certain other issues that can misstate charges or that are included in the modeled reimbursement would be denied charges. Did you exclude those from the model? Patient registration areas, like I mentioned before. Interim billing. So interim billing is kind of tricky. It depends on how your organization does it, and it can also understate charges. So improper application of short stays or similar cases, incorrect treatment of charges or payments for babies in maternity cases. All the plans handle those a little bit differently, and then should carve-outs be included in the calculation of stop loss? Is your stop loss first dollar, second dollar? Did you set that up appropriately? Those are just some common issues to look for in your modeling. If you see that it's not come out correctly when compared to how your contract is performing. I tend to see through negotiations with payers that was put out by Dilbert, where Dilbert's meeting with an individual in charge of contract negotiations, and he questions the negotiator why they haven't made any of the changes that they agreed to the month before, and the negotiator's response with that is, that's the process. He's not authorized to make any changes. He doesn't want to go to the executive that has the power because he doesn't want the executive to think that he's not capable. So he agrees to everything, but he doesn't make the change, and the cycle just goes on and on with the negotiator agreeing to everything requested, but implementing those changes. And this is done just to wear down the sides. This is sort of a stall tactic. I'm sure you guys have experienced that in your negotiations with payers, or perhaps you've done it on your own side. But the kind of ends with Dilbert asking for another edit. Negotiator responds, sure, see you in a month. So just a little bit of contracting here for you guys. So hopefully experience that. But on your end, go.
Thanks, Kate. We've all been there at some point in time, and probably on both sides of the table. I'm sure there have been times where we're waiting for the payers to respond, and there have been other times where we use the delay tactic to our favor. As you mentioned earlier, it does make sense if you're contemplating more oriented contracts to kind of go all in at the same time, because your products do need to align as you're beginning to change reimbursement. I think you provided a terrific list of items that everyone should be looking out for when you go through that critical review process in terms of true variances that could be happening or occurring within the payer contracting reimbursement variance follow-up process. I did want to circle back with the point around false variances. The administrative variances, if you will, can have a significant impact on organizations' workflow process. Registration errors, contract models not being routinely updated can lead to work variances that are in your team members' queues, but they're real collectible variances. And what we mean by a real variance, something that is a variance in the process, contract governance process, but it does have a collectible value. Eliminating or reducing these variances, these administrative variances, will lead to a more efficient process. And as an organization that has done contract management for 30 years, we identified 4 key metrics that we focus on, that we've quantified, and that we smart to. Fairly simple, but often simple can be profound. The first component that has to do with all contracts current to the period. It's like a very simple concept. Theoretically, this should be 100%, but it should be no lower than 98%. Variable is those occasions where the contract have an effective date that is retrospective. We all know Medicare is an example where they release a clarifying rule. So there are times that you do go back in time and you do need to recalculate accounts. But looking at and monitoring and ensuring that all contract models are current to the time period that you usually are in. As Father Time marches forward, we have to ensure that our contracts are also staying in sync with the calendar. The second metric we look at is calculation accuracy. Being a contract management vendor or system, a core value that those systems bring to the table is calculation accuracy. The calculation accuracy can be the tool itself, or it can also be how clear were contracts when you find the reimbursement rates and terms. There are times that interpretation does lead to errors. Users raise the question, when you find calculation errors, why aren't the calculations accurate? identifying the causes of the variances, and then establishing a time frame or milestones for your team or lender to correct the issue is really the best way to manage and ensuring that you're staying at a very high calculation accuracy rate coming out of the system itself. The item has to do with errors. PMMC monitors data on a daily basis. We report on a weekly basis. Data errors typically relate to synchronizing data, because you're obviously wanting to audit the same data that goes to the payer, being the scrubbed or 837 that goes from your clearinghouse to there. You're wanting to bring that into your contract management process. So when you're auditing off of what you've sent the payer, and it's or linking up the pay and adjustment data from your patient accounting system is denial data from 835 data. So keeping these three data sources in sync is critical, and monitoring the import file process should be routinely done. Lastly, as the fourth item, payment accuracy. And you should be looking at a payer scorecard process. Accuracy should really never be below 95%. You have some components of those false variances, but obviously you want to keep those to a minimum, and you want to squeeze as close as you can all those administrative variances out, so that the payment accuracy rate are truly those accounts that you can recoup payment on in that follow-up process. I believe we have a final poll question, Enrique.
Yeah, correct, Greg. Thank you very much. The final question, well, first we'll start with the results from the question. How frequently do you review done payment variances? 50% said weekly, 20% monthly, 2 quarterly, 1% other, and 2% do not regularly review. And now the final in-conference poll, do you use scorecards to track payer performance? The answers are yes, no, or plan to within 12 months. Again, that's, do you use scorecards to track payer performance? The answers are yes, no, or plan to within 12 months. In the interest of time, we will do a couple of Q&A, but we'll probably maybe just do a couple here. Here's one question that came in. Are there common contract management system communication accuracy errors that we'd be on the lookout for?
Common accurate errors. I know what we look at as in the prior four, are those 4 key metrics. Obviously, if you're working with a system other than PMC, you should ask how you're doing compared to those metrics. You should be asking your team how you're doing compared to those metrics in terms of how accurate are contracts being calculated. Do we have data that is fully imported into the system? Do we have contracts that are current date? And what overall payment accuracy rate from theirs, and what are we chasing after, if you will?
One more here. When monitoring whether contracts are current, are there any specific red flags that would indicate an issue?
That if you notice in a certain category that you're wrong across the board, then maybe perhaps look to see if you need a fee schedule update. Say, for example, all of your imaging reimbursement is off. The update to the fee schedule that perhaps you didn't load.
All right. If anyone else has any other questions, keep in mind we will continue to take questions at the end, and then they will also be available then on the recording if you have to get to a meeting afterwards. I'll just turn control for the final portion of the presentation back to you, Greg. That'll be first. Let me turn it back to Greg. All yours.
Great, Enrique. Wrap up. Scorecards or obviously the fourth of the four is scorecards are going to vary by organization and by personal preference. Here are a couple of metrics that we typically see and track from year-to-date performance, year-to-year performance, quarter-to-quarter. We look at collections by payer, collections by time of service, service lines are different examples, if you will. And there are different ways that the data can be presented. We can look at, as one example, scorecard, year-over-year collection. What's your overall collection rate? Are you seeing an increase or a decrease overall? Your collection by service line, or drilling down by department. Again, look at year-over-year comparisons. And then we look at, and organizations do, their why with the investment that you're putting into your contract management system, comparison to the underpayment recovery that you're recouping. Suggest organizations look at benchmarks. We often look at peer group comparisons on a per basis to give organizations a sense of how they compare. You can also do peer comparisons with your peer organizations from a benchmarking standpoint, regardless of whether you're going to be graphically presenting the data, light, yellow light, green light, bar charts, tables, regardless of the roll-up presentation of the data. The critical takeaway is to ensure that the detail behind the roll-up report is accurate. Understanding the accuracy rate, the false variances, understanding the accuracy rate of your calculations are critical. It noted, it's important to look for trends, looking for sudden increases or decreases in reimbursement. There's milestones that you're going to track and see with your payers. Know your payers are, their static statistics, understand your benchmarks for your organization. Those statistics are critical to evaluating individual payer performance and serve as the foundation for your next negotiating process, so that from the cycle just continues back to step one with payer contract negotiations. So this card drives your next level in that high process. For many of you that keep up with MNBC and CNN or news channels, we know that the effort to repeal and replace the Affordable Care Act has certainly slowed down the process and in some ways put on hold risk-based contract and reimbursement arrangements. I think we're going to see a continued push for that as employers look for continuing to control cost. That's part of the reason why we teamed up with HBI to put on the session next month with our networks. But your holes as it relates to risk-based contracts, most believe the traditional fee-service model is unsustainable over the long term. It will provide the baseline calculation for all risk-based contracts, so we have to be proactive in how are we going to manage the care and the cost associated with that care, and how accurate are we going to be in calculating and understanding the baseline fee-for-service models that we're in today, so then have that hierarchical building process as we move forward. Wide option of risk-based contracts may be a few years off, but now is the time for us all to really evaluate and look at systems and processes. Obviously, the baseline should include the ability to model all varieties of payer contractual reimbursement arrangements, understanding your administrative and executive team and boards, risk tolerance, and being willing to push the envelope in your payer negotiations. Every act should be modeled against your actual historical service mix so that you really understand areas that you can create upside value by just a little bit of reimbursement risk in managing the services based on those reimbursement terms. We should use this period of time to contract management process to eliminate those false variances or the administrative errors. This just helps ensure you've got a much more dynamic process that eliminates rework with payers. Obviously, you have a better working relationship with your payers if they pay it correctly, but in fact, you'll have a better working relationship with your payers if through the underpayment follow-up process, your underpayment appeal request has already been vetted so that you know it is a true underpayment. And, look to incorporate some type of payer scorecard process that measures the items that you need in a way that you want to see the data. As a ongoing cyclical process, these items will help ensure that your contract governance system, your trip management system, is always moving a step up as well as a step forward.
Thank you very much, Greg and Kathy. At this time, we will begin our final stuff. The last poll question results were: do you use scorecards to track payer performance? The results were yes, 30%, no, 35%, and to within 12 months, 5%. So, Q&A. We got a question that came in from Amy. Are there classes that you can take to better understand contracts and what to look for?
I am not aware. I know there are some there's some material out there as it relates to program in healthcare administration and finance. And Ricky, that may be a great to follow up with the academy on.
Greg, I think that's something that we will actually bring up with our learning team for sure. And if we then go to another question we have from Alden, what are the 3 sources needed to validate data errors?
So typically look at when data our system, the data successfully imports into our application, we typically will have what we refer to as an import error table. And when we refer to data errors, these are records that often don't complete the calculation process. They typically fall into common buckets, if you will. Things like the contract effective date is not, the contract has expired, if you will, and they've not rolled the contract forward. There could be a registration error, where there's a new payer plan code that has not been linked to a per contract. The records fall out of the trip management process if you haven't done that type of affiliation. Those 2 examples of the types of data errors that we typically see and manage on a daily basis.
Greg, and since there are no other questions in the queue, I'd like to say at this point, thank you to Greg and Cabby, and thank you all for attending today's Thought Leadership webinar hosted by PMMC, adapting to new reimbursement models, how to measure payer performance and maximize revenue. As a reminder, if you want CPE credits for attending this event, don't forget to answer the first question on the post-event survey that will pop up as soon as we conclude. And as a reminder, as Greg said, we'd like to invite you to attend next month's Thought Leadership webinar, also hosted by PMMC, on the subject of narrow networks, currently scheduled for August 15th. Thank you, everyone, and have a great rest of the week.